Hospice and Palliative Care, Paul Kohler, to move.
Thank you, Madam Deputy Speaker. I would first like to thank the Backbench Business Committee for granting time for this important debate, and colleagues from across the House for supporting my application and joining me today to discuss a subject which, to use an old cliché but in no more apposite a context, is truly a matter of life and death. When this House debated the Terminally Ill Adults End-of-Life Bill last November, the crisis in hospice funding and concerns over the provision of palliative care was a constant refrain, forming the subtext of many of the speeches from both supporters and opponents of the bill. As someone who entered the chamber that morning undecided as to how I would vote, I became increasingly convinced throughout the 5 hours of powerful argument and testimony that no matter what the House decided, the time had come to address the issue of hospice funding and the provision of palliative care head-on. For death is as much a part of life as living. Whilst as parliamentarians we readily focus on what makes a good life, we rarely consider what makes a good death. It's absolutely possible to have a good death, as I saw with my mother, who passed away in comfort at the beautiful Arthur Rank Hospice in Cambridge, and my father, who died in the exceptional palliative care facility at Bellevue Hospital in New York. As a family, we remember those times as sad but cathartic, with moments of laughter as well as tears, as when my father, somewhat confused toward the end of life, but with a glint still in his eye, asked as I sat next to him, stroking his forehead, whether I was a lady friend. Sadly, however, too many in our society do not experience a good death, and we need to start asking why. The Honourable Member of Spen Valley bravely took on that challenge in her private member's bill, and I hope this debate will afford us an opportunity to build on those foundations, of course.
And does he agree with me that the renewed focus on the hospice and palliative care sectors is extremely welcome and indeed overdue, and that the extra £100 million of investment shows how seriously this government is taking this issue, ensuring that people approaching the end of life are fully supported in whatever choices they choose to make at the end of life?
Thank you. I do agree. I do indeed agree with it with Honourable Lane, and I will be coming to those points further. But yes, I do agree. Today is consequently not about rehashing the arguments made that Friday, but to allow honourable members time to discuss and reflect on this separate but inextricably linked subject. Not the last word on hospice and palliative care, but an important step in forging a consensus that I hope will unite us, no matter where we ultimately stand on assisted dying. I began by referencing the crisis in hospice funding. Before I proceed further, I want to echo what the member of Spen Valley just said and thank the Health Secretary for the £100 million in capital and digital monies he announced last month. It will make a profound difference to the sector's current financial position. I've been asked both by individual hospices and Hospice UK to convey their genuine gratitude. In a similar vein, the government's recently announced commitment to extend the Children's Hospice grant by a further year is deeply appreciated and equally vital to maintaining levels of service in this heart-rending and profoundly important part of the hospice movement. However, these are only short-term fixes, and to fail to provide the long-term funding and certainty critical to securing the future of the hospice movement. Currently, only 1/3 of hospice funding is provided by the government, with the rest coming from charitable sources, leaving hospices vulnerable to increased cost pressures, as can be seen from a recent Hospice UK survey which found that at least 20% of hospices have either cut services in the last year or are planning to do so. Becca Trower, the clinical director of the wonderful St Raphael's Hospice, which provides excellent care to residents in my Wimbledon constituency, was unambiguous when she told me, "We have a funding crisis and we need to protect our hospice." Last year, that meant St Raphael's was forced to strip £1 million from its £6.5 million budget by ending its hospice at home service, which provided vital care, advice and support to patients and carers in their own home. A virtual ward, in fact, but not one that fitted within the NHS definition of such, so as to track the separate ICB funding available for such initiatives. In just 1 month, the cuts to this service directly impacted 26 patients. many of whom spent their last days taking up valuable hospital beds, dying in the one place they did not want to die, and putting further pressure on the NHS. It makes no sense at a time when the government is aiming to move medicine into the community for hospices to be forced into a position that achieves the opposite. A contradiction mirrored in the current funding settlement, where the government has given with one hand, taken with the other by increasing employers' national insurance contributions. The refusal to exempt charities will exacerbate the challenges confronting hospices. With the amazing Shooting Star Children's Hospice, for example, which provides wonderful support for families in my constituency, estimating this will add another £200,000 to next year's cost basis. Hospices need certainty. Doubts over funding undermine morale and saps energy, making both recruitment and retention of staff another huge issue for the sector. To address these problems, the government needs to introduce a consistent, reliable funding mechanism which reflects the rising costs of care. Hospices consequently need to be included within NHS's much anticipated 10-year health plan, while, in parallel with this, their staffing needs must be addressed in the next NHS long-term workforce plan. It should not be forgotten, hospices provide a variety of services in addition to palliative care, including emotional, psychological and spiritual support, physio and occupational therapy, practical support, complementary therapies, respite care and bereavement services. Much of this is beyond the clinical and not something the NHS can be expected nor can afford to provide. That is why no one I spoke to in the hospice movement thought hospices should be subsumed within the NHS. They provide a complementary service which extends well beyond the clinical and to which a charitable funding model is both more effective and appropriate. Of course.
Can I commend them for setting the scene so very well? One of the concerns that I have and others in the Chamber will have is the impact upon the workers in hospice. It's about not just about the financial implications, which is all part of the overall issue, but it's the issue of burnout. Staff are working long hours. They're doing that because they're volunteers in many cases, but they're doing that because that's what they're committed to. And does he share my concern that those who are doing that, that the burnout in hospice care will have an impact on the NHS in the long term?
Thank you for that intervention. I do indeed agree with the Honourable Member. We need more palliative care specialists, we need more training, and there's a real danger of burnout at the moment. Where I got to, I forget, but I think I finished that page. It is not just hospices which provide palliative care, of course. And in talking to specialists both within and beyond the hospice sector, I've been struck by their commitment to giving patients a good death and their frustration that so many do not receive one. As a palliative care doctor recently told The Guardian, I sometimes see patients who come into hospital in unspeakable agony and want their lives to end. It is not because their pain cannot be prevented, but because they are not getting the care they need. While a local oncologist told me, demand for services is simply outstripping supply. The majority of patients are not getting their end-of-life care wishes met. The specialist palliative care teams are very good. There are not enough of them, and they do not have adequate resources. Huge regional inequalities also exist in the provision and quality of services due to the vagaries of the current funding model. The Health and Care Act 2022 included for the first time a statutory duty for ICBs to provide palliative care. However, it did not include a minimum standard of core provision, leaving it to what each ICB considers appropriate. Freedom of information requests submitted by Hospice UK in 2023 found that adult hospice funding consequently ranged from just 23p to £10.33 per head of population across different ICBs. For children's hospices, the variations were even starker. Research from the amazing charity Together for Short Lives found spending per child with a life-limiting condition varying from an average of £531 in Norfolk and Waveney to just £28 in South Yorkshire.
On that note, will the gentleman give way?
Of course.
I thank you for giving way. On that point about the postcode lottery, and I know it's a very oft-used cliche by politicians, as I've heard speaking to Hospice UK, a single gift from a legacy covers the running costs for a hospice in the UK for, I think, for 5 years, and has done on one occasion. Does the honourable member agree that this example is one of the starkest extreme illustrations of how the current system is so unbalanced and leaves people living from street to street with such disparities of access to such an important element of healthcare?
Thank you for that intervention. I do indeed agree, and we'll be coming to some solutions that might address this issue, because we must increase the core responsibilities of ICBs in this area. Inevitably, much palliative care is provided not by specialists, but generalists, such as GPs, trainee doctors and community nurses, whom care of the dying is not their primary focus, many lacking the training, time and resources needed to provide what is possible. Not through their fault, but due to a system that does not regard palliative care as a core function. This is something all too evident at the outset of their careers, with one medical student telling me, "I only received 2 mandatory days training on palliative care in my entire degree. This is simply not enough, and we need to increase training across the board to ensure patients are given equal access to high-quality care." Since the Shipman case, there is also unacceptable legal uncertainty, particularly amongst non-palliative care specialists, as to the extent to which analgesics can be given in sufficient quantity to alleviate pain, even where that might hasten death. The system requires complete overhaul. We need more palliative care specialists and better training for non-specialists, including robust advice on the legality of giving sufficient pain relief to alleviate suffering, buttressed, if deemed necessary and appropriate, by more explicit guidance in the DPP's Code for Crown Prosecutors and the Lord Chief Justice Criminal Practice Directions. Whilst ICBs should be required to provide a minimum level of palliative care as a core function, this would have a transformative effect on how palliative care is funded, both within and beyond the hospice sector, rather than leaving it to the generosity of particular ICBs, such as South West London and Surrey Heartlands, both of which do all they can to fund local hospices, but within the constraints of a funding model that necessarily limits their abilities to do so. In concluding, I want to return to where I began. The debate is a matter of life and death. Ensuring a good death is not just important for the individual and at the end of their life, but for those they leave behind. Knowing someone passed away peacefully can bring real comfort to those mourning their loss. If I may, Madam Speaker, I'd like to end with the words of Fleur, whose son received end-of-life care at the wonderful Shooting Star Hospice. "Hospices are not just places where life comes to a close," she said. "They are places where those left behind learn how to keep on living. When my son Toby died, our hospice didn't just care for him, it cared for all of us, to give us a future not defined by trauma, but by love, resilience and hope. Months later, when my daughter had to step back into a hospital, the place where we had first been told we would lose Toby, she froze, overwhelmed by fear and grief. But when she returned to the hospice, the very place where Toby had taken his last breath, she ran inside, kicked off her shoes and threw herself into the arms of a nurse. That is what it's possible to achieve. I hope the government is listening. Thank you.